Good morning. So we're here to talk about testing the application of a citywide segmentation model. I'm Nick, this is Ben, and we're sadly not joined today by Alex, who was going to come but couldn't. I say sadly because the amount of analytical heavy lifting increases if you go this way. Please do bear that in mind. Just to start on Leeds, so Leeds is a big city, nearly 1 million people, and it's also a lucky city. And I say lucky from a systems perspective because it's got one acute, one community, one mental health trust, one GP confed, and one organisation that joins together all of the third sector partners. So it's very lucky. I work for the ICB in Leeds, and the function of the ICB includes in the name is integration, and also part of its statutory duty about improving population health and having insurance on spend. And actually, if you looked at all of those organisations, largely most people would say the same thing, like we're all here to make stuff better. But what gets interesting is when you look at how we do it, and we heard about that this morning when Michael talked about those organisational perspectives of making stuff better versus system or personal perspectives of what's better. So Leeds Teaching and Hospitals Trust will be like, well, the services I provide are great. The experience of people going through them are good. When you ask who's going through them, it's only pockets of the population. But actually, if you look at it from a personal level, you experience the services from across them. So you have cancer, you might be referred by your GP, you might be diagnosed by a GP, you might be supported in the community by the community trust, and if it doesn't go that well, you might actually end up in a hospice supported by third sector partners. So it's a system that's really important. So we asked the question in Leeds, well, how on earth do we manage and optimize a system from a people perspective? Because there's 870,000 of them and we can't do it at an individual level. But it's also really mad to try and do it at a total level because everybody's needs are different. So we started with a segmentation model. Okay, let's group people's needs in a way that is reasonably sensible and produces large enough groups that we can manage, track, and assess outcomes and track spend, but also representative enough of their individual needs so that people with cancer are talked about and managed in a different way to their health population. Sure. And so that is our segmentation model. It's representative of the size of the population. And I guess we talked about where the question came from. So we're underpinning a lot of our governance structure and our management structure in the Leeds as this. That's terrifying because I don't know if it's right. So we came to Ben and colleagues and basically asked the questions and said, after a bit of back and forth, are these segments internally homogeneous? Are they externally heterogeneous? Do they actually mean anything? So they're really representative of how people experience health and care and their health needs. And then the really tricky question is, let's imagine I have a person who is pregnant, has a long-term condition, and a serious mental illness. Which segment represents their needs? And with that, I'll hand over to Ben. Thank you.
So we started off with, we used the Leeds data model. So that's a combined data set of primary care, secondary care, basically all across the ICB, all the data we could want. It was aggregated up into yearly levels, so we could see for each patient things like activity and cost, and then break that down into primary, secondary. There was some data quality issues with community care costs, so that was removed. But this is basically our metric to divide the population, or at least to assess how well the population was divided. So just to start off, homogeneity. What do we mean? So we have 9 segments. Within a segment, we want everybody to look pretty much the same. So if you have a maternity segment, you want everybody to use the same, they go to hospital for the same amount of time, that kind of stuff. So we plan on looking at this by checking the variance. So we have a distribution of use and distribution of cost. So we just look at some very simple metrics. So variance and skew. So we want to see, is the distribution kind of weighted one side or another? Ideally, it wouldn't be. Ketosis. So we want to see how much weight there is in the tail of the distribution. So we have some extreme users, and as the NHS, obviously, we will have some extreme users, but we want to reduce the number of extreme users. And finally, we looked at the Thiel index, which is sometimes used, or which is often used in economic equality measures. So it's basically looking at how much of a service, for this example, is being used up by a small group of users. So you can kind of think of it as similar to ketosis, and just a slightly different way of looking at this. For heterogeneity, so this is for each of the segments. If we have two segments that are virtually identical in terms of use, that seems a bit pointless. We want to make sure all of our segments are distinct in terms of their use, at least across most of the variables. We have a lot of variables, so there can be some overlap. And we basically just assess this using KS tests, Polygon tests. So if we have a population, we have population patients, and let's say they're all in one complete group. We're looking at the ICB as a whole. This is not a very nice distribution. We're talking about everybody's part of one distribution. We've got a big standard deviation, high variance. It's quite skewed. If your mean was somewhere around here, and a weird distribution, much more this side. And then we have quite a long tail. So we can segment this group. This is all dummy data, but we could say there's a zero-use patient group, so this could be healthy. There's kind of a mid-use patient group, so this could be, you could think of it could be something like long-term conditions, and there could be a high-use group, and this could be end of life, that kind of thing. So ideally, this is what we want to see. For our homogeneous groups, we want to make as small groups as possible. Similarly, for our heterogeneous groups, we want to be split up. We just want to make sure they don't overlap, basically. So we applied some tests to our data. The data was not as nice looking as the dummy data. So these are our segments, and in the background you can see there's the same shape as like just the total population, just to show like the difference between the segment and the total population. And you can see for some segments they're virtually the same as the total population, and these are the ones that make sense. So children's segment and mostly healthy. This is where the bulk of the patients sit, and so obviously they are the same as the total population. But things like end of life have much higher usage, cancer, frailty, that kind of thing. We had quite a lot of zero inflation in some groups, so mostly healthy and children, but also long-term conditions, and there was a lot of skew. So the next part was looking at how do we want to justify the use of our segments? Are they actually useful? So based on this review paper, which looked at a lot of segmentation methods, and one of the things we pulled from it was that you can run quite simple, you can run bottom models. If you run a simple model, you can try and assess how well the model fits based on your outcomes. If you have a good segmentation model, then your Poisson model fits slightly better. It's always going to be rubbish, but if it's better, then that's a good thing. Final thing was we wanted to look at was our hierarchy, so in terms of where patients sit, was it justifiable? There are lots of different ways to check this. We had 9 segments. One of them was mostly healthy, we'll ignore that one. So 8 segments. What order should they go? So there's quite a lot of combinations, 40,000 combinations, and took maybe 5 minutes to run each. So we didn't want to run every single one and sit for 140 days. So we used a genetic algorithm just to check kind of lots of different combinations, orders of the hierarchy. For each order, we calculated pseudo R-squared based on the previous Poisson model fitting, heterogeneity score, homogeneity score. We took an average, and then we applied a penalty if our model was worse than the original model at any point. And we included a proposed hierarchy just so that any outcome would be at least as good as the proposed thing. That might be the best, and that's fine, but we just wanted to know. So what does this mean? So we start off, basically, you generate a score with this. I'm not going to go too much into genetic algorithms. Essentially, you have a group of hierarchies, so let's say you've got 10 hierarchies. We test them, generate a score for each. We then combine the results and change some of them randomly. So for this example, we have a low score. We might see, oh, if we put diabetes higher, the score gets better. If we swap out frailty and healthy, the healthy at the bottom, the score gets better. And then if we move diabetes down again, the score gets even better. So that's basically what it's doing. So those were the methods that we used. For the results, when we ran our heterogeneity score, we found that about 70% of the time, our segmentation model was better than the total population. So it's sometimes worse, but often is better. And we took that as okay because these are still quite big population groups, especially, like I said, mostly healthy children. The heterogeneity, for most of the combinations, they were quite well defined, so they were distinct. There were some particularly serious mental illness and patients with learning disabilities and autism. They overlapped quite a lot, as you could probably expect based on the variables we're using, so in terms of mental health usage and mental health justice. But mostly, across most of the things, they didn't match. And for the model appropriateness, calculating the bottom distributions, we could see how often fitted. We could see that just using a naive model, but that's taking everybody's metric, so cost or activity on their age and sex. That's not very good, obviously. But if we include a segment, it gets better. It gets about, let's assume, at least 6 and class word, pseudo word. And then if we had it in a subsegment, so this is splitting up even further, it gets marginally better. It's still significant, but it's decreasing. Finally, we looked at the genetic algorithm to get the optimal hierarchy. And so this produced this original hierarchy, so end of life at the top, and mostly healthy at the bottom. It's kind of what you'd expect. But when we discussed with clinicians, there were some modifications they wanted to see. So children, this should be a distinct group by itself, just based on their service usage, things that stuff for children, and based on how much they can make decisions for themselves. So that was moved right at the top. And maternity, this was second, but purely because this is very important in terms of what patients want. If a patient was in end of life and was pregnant, they might want to be treated in the maternity group rather than in the end of life group. So that was moved above as well. That gave us our final hierarchy.
Thanks. So I'll add there's lots of caveats for this. Yeah, I'll back out the way. So it's difficult data, it's new techniques, there's lots of uncertainty, high zero inflation. It was also delivered at pace, so thanks to Ben and Alex for doing so. And there's a lot more work needed on subsegmentation, which is why we've not shown it. That said, I and my team in Leeds were assured enough to use this segmentation model, and there are comparable ones out there, which is another bit of reassurance, to actually underpin our governance structures. So at place, Leeds has governance structures based on each of those segments. And around each segment, it brings together, apologies for the acronyms, but they are largely the acute trust, the community trust, public health, social care, the ICB, my organisation, the third sector, and a citizen representative. So we bring together partners around that segment, and we give them information, we say, this is what we spend, this is how you utilise care. Here is the proportion of your population that we think has high rates of unplanned utilisation. What are you going to do about it? And the bit we're working on at the moment is that interface back into the other organisations. But we see these population boards, as we call them, as fundamental to driving some of the changes we'd like to see in the city using that segmentation model. And there's some really interesting work coming out at the moment, including, as well as might be expected, the interfaces between boards themselves. And so they actually want to do a joint project, that makes perfect sense. We shouldn't be a slave to the segmentation model. But that is how it is run and applied in Leeds. And we're looking forward to doing some more work on subsegmentation and moving on to the next stage. Thank you.